Hello everyone, this is Judy Chen. Today we are going to discuss suctioning an endotracheal or tracheal tube. Here are the objectives: to describe indication for suctioning and to demonstrate steps used in suctioning a tracheostomy or endotracheal tube. Endotracheal tubes are inserted in patients whose breathing may be compromised when undergoing surgery or for those when mechanical ventilation is required. A tracheostomy is an opening into the trachea with the neck. A tube is usually inserted through this opening. Endotracheal and tracheostomy tubes serve as artificial airways that are used to maintain a pattern airway and to facilitate mechanical ventilation. The presence of these artificial airways prevents effective coughing and secretion removal. Therefore, periodic removal of pulmonary secretions with suctioning is necessary. There are several indications for suctioning, including the following: secretions in the artificial airway, suspected aspiration of gastric or upper airway secretions, presence of moist lung salts, rales, increase in peak airway pressures when patient is on mechanical ventilation, increase in respiratory rate or frequent coughing or both, gradual or sudden decrease in arterial blood oxygen saturation, or percutaneous oxygen saturation, sudden onset of the respiratory distress. Suctioning also may be performed to obtain samples of tracheal secretions for the laboratory analysis. Suctioning is always performed as a sterile procedure to prevent hospital-acquired pneumonia. Suctioning of airways should be performed only for a clinical indication and not as a routine fixed schedule treatment. Suctioning is performed with one of the two methods, open suction and closed suction techniques. In the open suction technique, after disconnection of the endotracheal or tracheostomy tube from any ventilatory tubing or oxygen source, a single-use suction catheter is inserted into the open end of the tube. In the closed suction technique, also referred to as inline suctioning, a multiple-use suction catheter inside a sterile plastic sleeve is inserted through a special diaphragm attached to the end of the endotracheal or tracheostomy tube. The closed suction technique allows for maintenance of oxygen and ventilation support, which may be beneficial in patients with moderate to severe pulmonary insufficiency. In addition, the closed suction technique decreases the risk for aerosolization of tracheal secretions during suction-induced coughing. Suctioning is aspirating secretions through a catheter connected to a suction machine or wall suction outlet. A series of equipment or supplies are needed for suctioning as follows: resuscitation bag, ambu bag, connected to 100% oxygen sterile gloves, portable or wall suction machine with tubing, collection receptacle and suction pressure gauge, sterile disposable container for fluids, sterile normal saline or water, sterile towel optional, equipment for suctioning, goggles and mask if necessary, gauze if necessary. A complete assessment should be conducted in the beginning, which includes physical symptoms and signs resulting from inadequate gas exchange associated with airway obstruction, such as secretions in the airway, inspiratory and/or expiratory crackles, restlessness, ineffective coughing, and decreased level of consciousness. Increased peak inspiratory pressures during volume ventilation or decreased tidal volume during pressure ventilation. Evaluate SpO2 or SaO2 levels, level of consciousness as well as ability to cooperate with the procedure. Ensure that the patient understands the pre-procedure teaching, and patients should be placed in a comfortable position, generally semi-fowler or folders. Nurse should perform hand hygiene, prepare the equipment for suctioning, and set the pressure according to patient's condition, usually 40 to 53.3 kPa for adult and less than 40 kPa for children. Apply sterile gloves, goggles, mask, and gown if necessary. Connect catheter to the suctioning device and suction a small amount of sterile water to make sure the equipment works properly. Prior to suctioning, hyperoxygenate the patient at least 30 seconds by ventilator or resuscitation bag. This is done to prevent decrease in arterial oxygen levels during suctioning. Disconnect the ventilator, gently insert the catheter without pressure until you feel resistance, and then withdraw the catheter by 1 to 2 cm. Rotate the catheter by rolling it with pressure while slowly withdrawing it for less than or equal to 50 seconds. Connect ventilator and hyperoxygenate patient again for at least 30 seconds. Rinse the catheter, discard the used supplies, remove the PPEs, and document. Suctioning may cause several complications: decrease in dynamic lung compliance and functional residual capacity, atelectasis, hypoxia or hypoxemia, tissue trauma to the trachea and or bronchial mucosa, bronchospasm, increased intracranial pressure, hyper or hypotension, cardiac dysrhythms. So, the following should be monitored prior to, during, and after the procedure: breath salts, oxygen saturation, respiratory rate and pattern, sputum characteristics, including color, volume, and odor, ventilator settings such as tidal volume, peak pressure, etc., hemodynamic parameters such as pulse rate, blood pressure, electrocardiogram, and intracranial pressure. American Association for Respiratory Care recommends several rules as guidelines for suctioning. Suctioning should be performed only when secretions are present and not routinely. The frequency of suctioning depends on the patient's condition. To prevent hypoxia during tracheostomy and endotracheal suctioning, the outer diameter of the suction catheter should not exceed 1/2 of the internal diameter of the tracheostomy or endotracheal tube. Hyperoxygenation always should be done before and after each pass of the suction catheter into the endotracheal tube, whether with the open or closed suctioning method. Sterile suctioning is necessary to remove secretions from the tracheal and bronchi to maintain a patterned airway. It is suggested that the duration of the suctioning event should be limited to less than 15 seconds. Performing suctioning without disconnecting ventilator is preferred. Therefore, the use of closed suction is recommended. Routine use of normal saline instillation prior to suctioning should not be done. That's all for this session. Thanks for joining us. Here are the references.